Thank you, Dr. Musa. Thank you, organizer, for the invitation and getting me out of the cath lab and invite me those couple days here in Dubai. So I'll continue talking about the calcified vessel, focusing mainly on the preparation and how we choose our device therapy. So this is a picture that we need to put in our mind. We don't have to do a stent like this, to put a stent and looks like this after. Now with the new generation third stents, with the small struts and with the improvement in the delivery system, you may be able to go inside the lesion. But this is not the goal. It's all about the calcium identification and vessel preparation. Dealing with calcium is really challenging because more complication and stent failure are likely to happen, and patients with calcium older and sicker with many other comorbidities. To deal or to manage calcified vessels, there are more steps to go with. First of all, we need to assess the calcium with imaging or angiography. Then we need to prepare our lesion according to the morphology. And this is the next step, which is very important to confirm our lesion preparation by the imaging. Then we need to optimize our PCI. Actually, there are many algorithms about how we approach the calcifications in the vessels, but the starting points and the common starting points among all these algorithms is the coronary angiography. This type of calcium, severe calcium, tram-track calcium in the both sides of the vessel, even before you inject the contrast inside the vessel, this is type of the calcium that needs special modification therapy. At the other type of the calcium, the invisible or mild calcium, maybe it needs only balloon just to push the calcium away and go ahead with your stent. So coronary angiography is your gate to go inside the algorithm and start your modification therapy. This is a study for in 440 patients where angiography, OCT, and IVUS were done to the target vessel. Calcium was identified by IVUS in about 83%, identified by OCT in 77%, and IVUS is more specific than OCT because it can detect the deep calcification that it's beyond OCT penetration limits, and angiography picks up to 40%. But here we may say it's only intravascular imaging to go with, but we need to see the whole picture. And the whole picture is here: mild and moderate calcification does not lead to stent under expansion. Severe calcium only seems to be a good marker for stent under expansion. So again, severe calcification on the angiogram is our thresholds for specific calcium therapy. One of the important points for inside the algorithm is the balloon and crossable lesion. Likely, fortunately, the solution here is easy because the atherectomy is the treatment of choice for any uncrossable lesion. This is a case, female patient, around 80-year-old, diabetic, chronic renal failure, presented with acute coronary syndrome, with here balloon and catheter, imaging catheter, could not cross the lesion distally. But fortunately, microcatheter could cross distal to the lesion, and finally we could, after, change our workhorse wire for the rota wire, and there we performed 1.75 burr, and this is followed by more modification of the lesion with NC balloon, and this is final after 2 stents implantation. Case number 2 with a different scenario. Here, in this case, we couldn't cross with both balloon and microcatheter. So this is a case, young patient, diabetic, presented to another center with non-ST elevation myocardial infarction. In this center, earlier, they failed to cross the lesion with a balloon and microcatheter. Despite the good support they have there with a guide extension, then they refer the case to us. I discussed the case. Maybe Dr. Musa can remember this case. We did it together. We discussed the case, and the solution here, we decided to go directly to cross with rota wire directly. And here we should be careful because the wire is not user-friendly that much. It can kink easily, but fortunately we crossed distally. Then we started our rotation with 1.5 burr, that followed by shock wave, and this is our final result. We confirm the apposition and expansion with IVUS. So here is the rule number 1 for uncrossable lesion. If you couldn't cross with the balloon, but you could cross with the microcatheter, so go ahead with atherectomy. Rule number 2, if you couldn't cross with both balloon and microcatheter, but you try to go with a rota or fiber wire, if you can't cross, so that's fine, go ahead with atherectomy. If you couldn't cross, so use laser if it's available. Sometimes if it's not, you can try to increase support with anchoring balloon or guide extension, or if you have the CTO skills, you can try to use re-entry or even move the cap technique, Carlino technique, or whatever. So I'll speak now about the rotablator and orbital atherectomy, how we select or how we choose between these two devices. Actually, for the most indicated cases, either rotational or orbital can be used successfully for the lesion preparation. We select among both according to the experience and the local availability and according to the cost of the device. We all know the rotablator, which is rapidly rotating burr, which is distally coated with diamond crystals. It comes in many sizes, 1.25 up to 2.5. It needs guiding catheter from 6 to 8 French. And usually remember, it can ablate only in the forward direction. There is no backward ablation. So that's why I try myself to stay away as much as I can from 1.25 burr, because this is the one will stuck inside the vessel. The other one is the orbital atherectomy, which it works in a different mechanism. It orbits around the vessel different than the rotablator. But the good two things about the orbital atherectomy, that it comes in only one size, 1.25 in 6 French guiding catheter. The other thing, it can ablate both in the forward and backward direction, so it doesn't stuck usually. And we increase the diameter of ablation by increase the speed from 80,000 up to 120,000 RPM. Some centers have an access to the laser atherectomy. We do have it in my center. We use it many times. It depends on UV energy, which creates a vapor bubbles that can go inside the intima and media to crack the calcium. It comes in 4 sizes, but don't forget usually to flush during ablation, because saline and blood can cause huge dissection sometimes and perforations. The next step or important step in the algorithm, if you can cross with a lesion, and this gives you a chance to go inside with your intravascular imaging. And in this case, you can know more about your morphology. Is it superficial or deep calcium, concentric or eccentric calcification, or is it nodular calcification? So you choose accordingly your modification therapy. Using intravascular imaging also, it can give us 2 simple scoring system. For OCT, it's called rule of 5, depending on thickness, vessel arc, and length of the calcium. If it's 3 or more, go ahead with the calcium advanced preparation. Same story for the calcium with IVUS, but there is no thickness measurement in IVUS. If the score is 2 or more, consider advanced lesion preparation. This is a case where we did with orbital atherectomy for the LED and RCA for a 71-year-old female diabetic with ACS. You can see the calcified arc around 360 with the calcified nodule after in the distal to mid RCA. Score is 2. LED, again, we have 360 arc, proximal and mid segment. So here we choose to go ahead with orbital atherectomy. We used 120 RPM for the RCA, sorry, and we used 80,000 RPM for the LED because the different diameter. So we try to use one device for both vessels, and this is our final after stenting. What is the limitation for atherectomy? The main limitation is when you did atherectomy, but the balloon did not expand. This is either because the burr is small or there is a wire bias. Wire bias, I mean, it means that the rota is pushed away from the plaque, as you can see here. So you are not doing the favorable effect that you wish. So atherectomy or the modification by orbital or rota, it's based on the wire bias, but unfortunately, it's also limited by the same bias as well. This is another example when your imaging catheter is pushed away from the lesion, and this is after ablation. We just have a hole in the vessel, and maybe that we don't want. Another limitation of the atherectomy, it's no reflow, hemodynamic instability, perforation, and burr entrapment. This is the new player in the game, which is the IVL. We all know it has two emitters which give pulsatile pressures. It causes microfracture in intima and media. It comes in different sizes from 2 to 4 millimeter, all 12 millimeter in length. This is a case where the patient came with non-STEMI and cardiogenic shock with severe calcified arc around 360. According to what we choose this time, we don't want to go ahead.
It's okay.
2 minutes.
Please, 2 minutes. Okay.
We don't want this time to go ahead with atherectomy, rotational, or orbital because the complication that we expected, no reflow or whatever. So we did IVL, and this is what we have after the ablation. And IVL is really safe, and the safety is tested in the all disrupt studies. It was safe and effective, no serious issues, no complication, no perforation, no dissection, no slow flow. So it's really safe. So here is, if you can cross with the IVL, so go ahead and choke the lesion. If you can't, just go ahead with the atherectomy. Regarding calcified nodules, it's when the calcium is protruding inside the vessel. So here, another case, big vessel in the RCA with calcified nodule, confirmed by intravascular imaging. We choose to go ahead with 2O burr that followed by IVL, and this is what we have after stenting. So the treatment of calcified nodule, maybe atherectomy and RVN are both an option. Atherectomy you need to choose a proper device selection. A combination therapy should be considered. Just for the sake of the time, for the eccentric deep calcium or under expanded stent, here IVL may be the device of choice because of the wire bias. It can take you away from the lesions. So, but here, can we use the angiography to confirm our calcified modification? Yes, sometimes angiography can tell some information. So in the left side, if you use the stent boost or stent enhancement, and you found that the wire is hugging the lesion, so or the calcium, so in this situation, that means the balloon is pushing the adventitia. So don't stent. 1 more minute. Last minute.
Reem, give 1 more minute.
So in this time, don't stent, but on the other side, if you're wire in the middle of the balloon, so you can go ahead with stenting in this time. So last slide, conclusion, how we select our modification therapy between rota, orbital, IVL, and laser. For uncrossable lesion, we can go ahead with rota and orbital, both are an option. For concentric calcification, rota, orbital, IVL, an option. Eccentric and deep, it's IVL. Nodular calcification, you can go for orbital for its specific Mechanism of action for IVL, also an option. Aortoosseal lesion, orbital is the best option. For under-deployment stent, IVL is the first option, still off-label indication, and laser also can be used with contrast injection. And thank you very much. I'm sorry.